less than 2 minutes ago, I got in the home.
Ah, great.
Nice.
Hello, my friends. How are you?
Very good.
Very well, very well.
Wow, Costantino, you have a voice like Barry White. Wonderful.
Wonderful. Wow. Sebastiano was
Yeah,
very decisive, today. He started immediately with the video before we start speaking.
yes, yes. You see,
Exactly.
Sebbi is very proactive today because our Sebino is on the train, doing direction from the train. Can you imagine?
Without girlfriend.
Yeah.
You don't know that.
Okay. So the question of the week is, can you accurately identify cutaneous metastasis with dermoscopy? Yes, no, sometimes. By the way, you cannot imagine. I was just reviewing. So you know that I get new dermoscopy papers immediately as they show up in PubMed. And I just got a brand new, let's say review. It's not a systematic review, but by the way, it's a well done review on skin mets, and I will show you later.
Okay, great.
Yeah. So the results of the question was sometimes,
Sometimes.
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 And I think I agree. Sometimes.
Yes, I
But
also agree.
did we say hello to UK,
No, we didn't say
to
anything. Yeah.
Jerusalem, to Denmark, to Chicago, to Italy, Madrid, Ukraine, Armenia, Brazil, Greece, Albania, Canada, Romania, Beirut, Serbia, New Zealand, Bosnia, Brazil, Lima, Sweden, Riga, Poland, from where I just came back. I was in Poland until 2 hours ago.
Yeah.
Wonderful, wonderful, wonderful. We are many, as usually,
Many,
from all
many,
over the world.
many.
So we're going to discuss about skin mets.
Yes,
Skin mets.
yes. It's a kind of heavy topic for today, right?
Yes, indeed.
Yeah, yeah, yeah. And
Okay, let's start and we see how the flow.
yeah. Costantino, I suppose you prepared
A
kind of,
brief, a brief presentation.
yeah.
Uh, by the way, I need to shave. I just I just realized that I need to shave. Okay,
Yeah.
episode 13. And talking about skin meds, we need to reference this really nice study that was done under the auspices of the IDS by Danica Teodorovic, our dear friend from Serbia. You can see the very big team that participated, along with the IDS study group. Imagine how many people participated. But that concluded to gathering 583 patients with 632 cutaneous metastases, a very big number, where the most common primary tumors were melanomas and breast cancer. This was published in GEDV in 2024. Really nice study. Uh, Melanomas and breast cancer most non-melanoma cutaneous metastases were non-pigmented, as we can imagine. And interestingly, of 169 distant metastases, they appeared on the head and neck region. So distant metastases very commonly can present on the head and neck region.
32%, one out of three. Yeah.
Yes, impressive.
Yeah.
Uh, so some interesting dermoscopic findings. Some were pigmented, but the vast majority were melanoma, so this makes sense. And 309 were non-pigmented. Vessels were noted in almost half of the lesions. In dermoscopic evaluations, prominent vessels were observed in all lung cancer, sorry about that, in all lung cancer metastases and in 96.6% of breast cancer metastases, with linear serpentine vessels being the predominant feature. Ulceration was detected in 11% of metastases, with squamous cell carcinoma, gastrointestinal tract, and lung cutaneous metastases exhibiting the highest frequencies. And as we all know, it's a well-established knowledge, among pigmented melanoma metastases, structureless blue was a dominant pattern. Here are some melanoma metastases. So we can see the structureless blue pigmentation that we very commonly see adjacent to the tumor, here resembling blue nevi. Actually, this is a very interesting discussion, I think, that still, despite all the progress and all the knowledge, still many people are very afraid of blue nevi
Yeah.
because it could be skin mets. And usually they're sent to us like, could this be a skin met?
Yeah.
Without a history of prior known melanoma, no, it cannot be. And the non-pigmented, as we all know, are very vascular, chaotic lesions. So, frequency and categorization of primary tumors from this really nice paper from Danica. Is it Danica or Danica?
Danka, Danka.
Danica.
Danke.
Danica, from Danica. We can see that melanoma comprises 75% of the lesions and dermal malignancies 21%, with breast cancer being the predominant. We all know that breast cancer can very commonly metastasize to the skin. Then we have lung cancer, gastrointestinal tract, renal, and other. Whereas from skin cancers, basocellular carcinoma and squamous cell carcinoma. Here, from the paper, we can see some examples of metastasis from non-skin tumors. So here, for example, we have a breast cancer metastasized to the head and neck region. Here, a pigmented lesion on a patient with a history of mastectomy and breast cancer. For me, this was the most interesting. This was a renal cell carcinoma metastasizing to the nose. I've
Mhm.
never seen anything like that, to be honest. And I have some examples of my own. Here we have, I think, a comparatively easy diagnosis. A patient who presents with this lesion, and this is dermoscopy. Do you have any question of what is that?
Yeah, it's breast cancer.
Breast cancer metastasis,
Yeah.
exactly.
Yeah.
Here, patient on the trunk with this dermoscopic image, linear serpentine vessels, and this extensive ulceration. Do you have any idea where this may come from?
Yeah.
Stomach. Stomach.
It was renal cell.
Renal? Renal.
Renal cell carcinoma, yeah.
Yeah. Yeah.
Here, a dubious case, and this is the reason that I'm showing it, because more or less I would like to discuss it.
Looks like extra mammary pageant.
Pudgy. Extramammary pudgy.
Exactly. So that was my idea as well. But the patient has had a history of genitalia carcinoma, and this has been growing within 1 year. And actually, this was a metastasis from her genitalia cancer. Popular, right? Very interesting. I also biopsied these as extramammary pagettes.
Mhm. Yeah.
And I think that here we can guess the diagnosis.
Melanoma metastasis.
Exactly.
Yeah.
Melanoma metastasis. Here you can see the abundance of mets in this very aggressive tumor. And here, white structureless. Can you guess what it may be?
Is it scalp?
Yes,
Yeah.
scalp.
Yeah.
So it's a metastasis from a squamous cell carcinoma here in transit. And that's it from my side.
Wonderful, wonderful,
Perfect.
wonderful. There are, yeah, many interesting things that you mentioned. First of all, 1 out of 3 skin metastasis coming from any kind of malignancy is localized on the head neck region, which is really a lot. So it looks like scalp is really a preferential location for skin mets of any kind.
Yeah, that's true, and that's also
Yeah.
a clinical observation. It's not.
Yeah, exactly.
But
Eh,
guys, sorry, say Jebi.
No. And also if I understood correctly, because there is a party ongoing here. There is such a high noisy music. Can you hear it? No?
No, we cannot.
No? Okay. So, by the way, what did you say? That 50% of melanoma mets are pigmented?
Yes.
Okay, 50%. Okay, good.
We have a wonderful question by Doriana. A
Yeah.
wonderful question.
Yeah.
In case of a patient with both primary melanoma and local multiple satellites, around who comes for the first evaluation, would you first take a biopsy from one of the satellites for staging or proceed directly to excision of the primary melanoma? Thank you.
Well,
So,
both. You have to excise the primary and the satellite. So then you can, because I mean, we are still not in the phase of neoadjuvant when the primary is
still there.
yeah, we are
Exactly.
not in that phase. Probably in
Yet.
the future, yet.
Exactly.
Probably in the future, it will be the case that we can do neoadjuvant even before excising the primary lesion when we have satellite metastasis, but it's not the case at the moment.
Yes.
So for the moment, we have to biopsy the primary and the satellite. So then we can skip the sentinel node biopsy because we know that the lesion, the disease is already stage 3.
Yes.
Yeah.
But I
Exactly.
think this is a beautiful future direction question.
Yeah.
So what do? If you already biopsy and you have the confirmation of metastatic melanoma like in transit, you could potentially have the immunogenic stimuli there and proceed to neoadjuvant
Yeah.
and then subsequent removal.
Okay.
Exactly.
Nisa, would you like to show your cases?
Sure.
Hello, Jeffrey. Hello, Emilio. No, we will not start now. No.
Nice.
Okay. I'm going to share right now.
Not the AI ones. The real deal.
Okay, my dear friends, the patient is 58-year-old male, and there are some recent onset nodules, and it was just like a lipoma, not very firm on palpation, but there were many, as you can see. So the color is skin colored, and my preferential here was for sure metastasis, but what can it be? What is the origin of this metastasis? Here we can see there are a lot of nodules, And here's the dermatoscopy. It's just skin colored, no vascularization, no pigmentation, just skin colored.
Yeah, but these are
So
not
what's your preferential there?
these are not cutaneous. These are subcutaneous metastases.
Yeah,
So
subcutaneous.
so
Exactly.
I would probably go with lung cancer.
Lung cancer. Okay. Let's just concentrate on the photo, clinical photo. Do you recognize something in the patient? Just look at the finger.
Yes,
And here
melanoma.
here you can see there's an amputation and the patient has a history of acral lentiginous melanoma. And when we look at histopathology report, he was diagnosed with melanoma in 2018 and he was 50 years old at that time. And breast of thickness was 3.5 millimeter, ulceration was positive, and mitosis was 4 in this case. And the patient just went to the controls for 2 years, and after COVID, he didn't go to controls, and these nodules are just newly developed nodules. And I saw this patient in January 2 months ago, and unfortunately, the patient died just 1 month later after the onset of all these nodules, and it was very progressive. And I just want to show you the PET-CT. You can see the metastases everywhere, even in the scalp. Normally, with PET-CT, the metastases are not so visible. With PET-CT, MRI is much more useful in these cases, but still we can see the metastasis even with PET-CT. Normally, as Konstantinos mentioned, we expect to see the metastasis as blue nodules or pink nodules in cutaneous melanoma metastasis, as here you can see the metastasis, and here are some more cases with cutaneous metastasis. Some of them are black, some of them are purple, some of them are pink, and some of them are bluish. They're very colorful and all melanoma metastases. This is the second case that I observe skin-colored metastasis in a patient. I'm not so sure if you have patients like this with skin-colored metastasis in melanoma patients, but it's interesting, I think.
Yeah.
And here are some more cases with melanoma metastasis. Another case, the patient has a lung cancer, and he was treated in the thoracic surgery department. And they consulted this patient for this new onset lesions, which were, you can see, dermatomal. And here, this is the back. And there are some vesicles, pustules here. And the doctors consider that he has a zoster, herpes zoster, because they were all painful. And at first glance, they were really looking like a zoster because it was dermatomal and there were some vesicles and pustules, but the skin was very firm on palpation. And we made a Zonk smear. There was no finding which were supportive for herpes infection in the Zonk smear. And then we took a biopsy from the vesicles and from the back, because the back part was much more suspicious for cutaneous metastasis. It was really very firm on palpation, and there were a lot of branched and serpentine vessels on the back, and they were out of focus, which was very supportive for cutaneous metastasis. And all the biopsies that we took were consistent with metastasis. And here you can see the zoster form involvement. And it was really looking like herpes zoster, especially from the front side. And this patient is also very interesting because the patient also has a history of lung cancer. And these nodules, it was a periangle, as you can see, developed recently on the left thumb. And he was under remission because he has some cycles of chemotherapy, and there was no metastasis at that time when he presented us. Here's a dermatoscopy. here you can see a thick vessel. With these sort of vessels, thick branch vessels, they're generally consistent with metastasis. And here you can see a large ulceration, white structures area, and some rainbow pattern here. But the vessel here is really very thick, and it was extremely painful. And you can see the vascularization under the nail plate. You can see the vessels also here. And histopathology, and this is just 2 weeks later. You can compare the clinical presentation. It's
Wow.
really growing very fast while we were waiting for the histopathology result. And histopathology came as, and here is the direct graphy. You can see the lytic lesion here in the bone. And histopathology was consistent with moderately differentiated